We shall now go on to
Thank you,
Dr.
ma'am.
MARIAN PAULY, who's a senior consultant and head of oculoplasty, orbit, ocular oncology, and prosthesis from Giridhar Eye Institute based at Kochi. And she is going to talk on another, I don't know whether it's controversial, but another very interesting way to look at it, a bilateral external DCR, her views. On to you.
Thank you, madam. Thank you, Dr. Chitra, for giving me this opportunity. Let me share my screen. So I hope my slides are visible. So I'm going to speak about a little controversial topic. So bilateral simultaneous external DCR, my views. As we have already listened to all the previous speakers. DCR is the gold standard and the success rate is around 90 to 95%, even more than that, like almost 99%. And the incidence of bilateral nasolacrimal obstruction is around 9 to 18%. And even in bilateral cases, nowadays, surgery is done unilaterally. Even in bilateral cases, the main concern is bleeding, which we have already discussed. So we did a small study like 3-4 years back. Our hospital, this is my hospital experience. And we divided the success rate into functional success and anatomical success. So the age group was around 5 to 81 years. The mean age was 51.1. 3 patients had congenital and rest were acquired. Follow-up was around more than 2 years, like 25.8 months. 4 patients underwent surgery under general anesthesia. That was 3 kids, 3 children and 1 adult. The main duration of anesthesia and surgery is around 85 minutes. 1 patient had bleeding. Intubation was done in around 40.6% of eyes. So almost anatomical success obtained in 87.5% and functional success obtained in 93.7%. So now what are the concerns in bilateral simultaneous external DCR? One is the amount of time taken. Second is the risk of complications. And third, whether it will compromise the surgical success. So what is the literature says? So in a normal condition, the surgery is brief surgery that is taking less than an hour. According to Tarbet and Custer et al., they took the mean duration was 53 minutes and Malhotra et al. Took 41 minutes. So when you compare the literature, SEC et al. Published in 2007, they took a mean duration of 89 minutes. Yüksel et al. In 2015, 86 minutes. Whereas he did bilateral endonasal endoscopic, it was 44 minutes. In our study, it was 85 minutes. So the time was almost comparable. But if you see one eye, it will take 53. That means 2 eyes will be more than 100 minutes. Malhotra et al. Took 41 minutes for 1 eye. So it's almost comparable. So in tips in bilateral DCR, you should not block both eyes together. Always block sequentially. Suppose block 1 eye first, then do the surgery midway. That is after the punch, you can block the other eye. Similarly, don't pack both eyes, both noses together. Pack nasal pack is also sequentially. And after finishing the 1 eye, we have to, during the first eye surgery, if possible, cauterize the edge of the posterior flap, or you can suture the posterior flap so that it minimizes bleeding, as well as you need not pack the eye. So what are the advantages for bilateral surgeries? One is short operation time, low medication usage, especially painkillers, even antibiotics also. Hospital cost is also less, fast recovery, and the absence of stress from a second surgery. So in our study, what was the success rate? It was around 87.5%. So comparing to the other studies, it was like little less compared to the previous studies. So in fact, when we analyzed our cases, more than 50% of patients were using anti-glaucoma medications. It has already been reported that topical anti-glaucoma therapy as a risk factor for nasolacrimal duct obstruction in AGO 2008 by Cedar et al. So it can be a causative factor for NLDO, or it can be a risk factor for failure in DCR. We know the pathology is mostly, especially in primary acquired NLDOs, inflammation, and anti-glaucoma medications can cause chronic irritation of lacrimal mucosa if they are not doing punctal occlusion. In our series, 2 patients failed. Actually, first patient was using 4 anti-glaucoma medications. Second patient was on 3 drugs. This was a little controversial topic regarding anti-glaucoma medications. So in my view, simultaneous bilateral external DCI can be done with a great success, both in adults and in children. And simultaneous surgery is always of both medical, economic, and social advantages. It can be either external or endoscopic. So thank you so much. These are my views. Thank you.
Thank you. Dr. Arvind, do you have any question to take before we move on to our last speaker?
This is always a preferred topic. We do both sides when the patient has a bilateral pathology. But I think ideal patient selection and eventually what you are comfortable with makes all the difference. In fact, I think I would like to ask doubts, but let's just finish Madam's talk, and if you have time for discussion.